Hello, good evening, everyone. My name is Dr. Fahim Shakur, and welcome to another weekly episode of the Bed Talks podcast, live on Facebook Live, as well as YouTube, and also on Pendle FM 103.1 FM. I'm really pleased that tonight we'll be talking about ADHD, which is Attention Deficit Hyperactivity Disorder. And over the next hour, if you have any questions to do with that topic or any actual issues or areas that you'd like discussing, please do actually text us on the usual number on WhatsApp or even on the studio line. Do get in touch with us and we'll take your questions. Also on the YouTube link as well, there's an actual function there to actually give us questions, and we'll put them to our special guests tonight. Over to you, Mehran, to welcome our guests and introduce them to the audience.
Thank you, Fahim, and welcome everyone. So you're listening to Med Talks, same time, same place on a Tuesday. So I'm going to start with Dr. Khurram Sadiq. You may have seen him from our previous shows. So he is one of our regulars, but clearly he brings along a wealth of experience as well as keenness to educate and raise awareness. So he's a consultant psychiatrist. He is actually quite busy this week, and he's starting off with Med Talks. So thank you again, Khurram, for joining.
Very welcome.
And our next guest is Dr. Dheeraj Chaudhary, who I was actually a trainee with quite a few years back now. But he is a consultant forensic psychiatrist, so he's got a great deal of experience in that department. But he's also got a special interest in ADHD. So thank you again for joining, Dheeraj.
Thank you for having me.
So I'm going to start with yourself, Khurram. So we know a little bit about ADHD in the sense that it was kind of referenced in that Fidgety Philip poem back in the 19th century. I'm not going to go through that because it's quite extensive, but it clearly talks about some difficulties there. So could you educate the audience exactly what is ADHD?
Basically, as the name implies, attention deficit hyperactivity disorder. So it means that people can be very fidgety, very hyperactive, at the same time, because it works on a triad: hyperactivity, impulsivity, and then inattention. And then there are subtypes. Subtypes are hyperactive type, hyperactive-impulsive type, which is unable to sit still, very fidgety, very restless inside, get distracted easily by things around that person, environment, noises, extremely impulsive. There's no latency period between thought and action, so they don't get any time to think about things, and they kind of regret things afterwards. So that is a hyperactivity type. Then we have the inattention type, which used to be known as ADD in the past, but now we call it the ADHD inattention type, inattentive type of ADHD, and it is more to do with not able to have a focus, not able to do things diligently, gets bogged down by admin kind of work, paperwork, get bored easily of things, switch from one task to another, keeps on having incomplete series of tasks. And then there's the combined type, which have both symptoms of inattention, hyperactivity / impulsivity.
Fantastic. And Dheeraj, how common is it, and what age does it usually tend to present?
Okay, ADHD is actually a common problem. Technically, it's a neurodevelopmental problem, as it is now recognized as. In children, very conservatively speaking, 5% of children have ADHD. And it is now thought to persist into adulthood in almost at least 2/3 of cases. Conservative estimates would tell you 2.5% of adult population has ADHD in UK. Now, prevalence rates vary across the countries, and depend on whether they were screening tools or they were mass surveys. But it's a common disorder, as I'm saying.
Great. Khurram, you gave us the definition to start off the show, and that's always a good place to start. I want to expand on that in terms of where does it fit in with the broader range of learning difficulties or specific learning difficulties, as it's almost like a Venn diagram. There's overlap. They're not always in discrete areas. Can you tell us where ADHD lies in that circle?
ADHD, it does have a comorbidity with intellectual disability, but again, it is 20 to 30% of the patient. But then you have to be very careful because there is inherently a lot of agitation in that group which are intellectually disabled, and especially if you're going from moderate to severe and then profound disabilities. So it's a very sensitive area. We have to tread in it very sensitively, but a rough estimate is about 20 to 30% of those who have got intellectual disability, they do have ADHD. But again, going back to Dheeraj, what Dheeraj has just said, because it's a very important thing to notice that ADHD is it happens across the timeline. It is neurodevelopmental disorder. Some people can actually remit because the hyperactivity decreases over a period of time. But one of the reasons that the discrepancy between having more ADHD uh, in children as compared to adults is there's no expertise in adult. There's a lot of misdiagnosis, especially people who miss the net. They're misdiagnosed with a lot of other disorders, for example, cyclothymia, social anxiety. It can be mental and behavioral problems because of substance misuse, and especially emotionally unstable personality disorder. So it's not that it recedes, it is because the expertise is not there to diagnose those people.
Excellent. And Dheeraj, obviously you're an expert on ADHD. You have clinics on this. I've been looking at your website. And how does it actually present to you? I mean, do they come with other conditions, or have they already worked out that they have ADHD? Can you give us an idea and the actual day-to-day presentation that it's coming to you?
Sure. I see more of adult cases, and thankfully, due to increasing awareness, and people do research a lot these days. Unfortunately, the waiting list in NHS clinics is severe, almost up to 5 years in many places, and they look for clinics available near them. Now, in terms of presentation, I see university students, I see professionals, I see doctors, PhD scholars, and they come to realize that for some reason their problem was missed when they were younger. And it does happen in today's day and age, unfortunately. University students, for example, they reach uni and they realize that they can't really cope with their educational work. The submissions are late. They have poor attendance. The risk of drug abuse and other things increase. They really can't cope. They come seeking help, and during the assessment, one realizes, as a child, even though they had symptoms, they had a good level of scaffolding around them with their teachers or parents providing that support, that the ADHD was managed. But suddenly they come to uni, they can't manage it. They get eardrops, or they fail, they lose the course, they have to sit out, and their trajectory totally changes. Now, take, for example, a doctor in clinic. Some of them really struggle with managing their clinics, managing admin time. They make mistakes in prescription. I know, for an example, the whole life of that doctor was being supported by their admin staff, and without that support, they would not really function. So that admin staff was providing a scaffolding again. Another example in sort of adult life is relationship problems. If there is a couple with one partner having ADHD and one not, there is a big imbalance between that relationship. Because of the ADHD and its manifestations, one partner already is facing struggles, but the other partner also suffers, and there starts the marital or relationship discord. Because of impulsivity and other things, alcohol issues, or not paying bills on time, or increasing risk of domestic violence, and then they present in clinics elsewhere and in mine as well. So different people at different levels, different variety of work and professions, they all have ADHD, or they can have ADHD. It's not limited to people in a certain background or a certain level of education, and they are thankfully seeking help, and we need to do more.
And it's, in all honesty, in addition to that answer, Dheeraj, it's great to have so much engagement with the audience. There's lots of people watching. Please do ask us questions. We will try to put them forward to the experts, as well as do subscribe to our channel in addition to that. Khurram, I did want to come to yourself. So, are there any gender differences in how they present? Because there is some evidence to suggest ADHD in girls may be more difficult to elicit.
I was waiting for this question because it's a very common theme to ask in ADHD as well as autism spectrum disorder. Again, there is the disparity between the genders, like 5-to-1 ratio is usually there. But I think in reality, it is actually the masking that happens in girls. And females, they do mask well, they do mirror things well, they're able to manage things well, and hence their diagnosis gets missed a lot. I have this strong belief, although it's not backed by any studies, but it's backed by my own professional judgment and my expertise in this area, that I think the difference is less. Because we miss a lot of cases in female. Plus, again, we don't have the expertise to spot these cases, especially at a school level or at a later level, because of the masking and mirroring amongst the females.
And Dheeraj, Fahim kind of alluded to the overlap, and I guess this was supported by Khurram as well. We did touch on the commissioning difficulties, because there is an argument to say that this is part of core psychiatry. Where is the gap, and how do we support services in making sure that this is understood and well managed in the community?
See, as you know, we are already discussing, ADHD is still underdiagnosed, still undertreated. Causes are varied, really, whether it's because of local funding issues or major charities or the awareness around ADHD. To be honest, last 10-12 years, there's a lot of increasing commissioning happening around specialist ADHD clinics. But I think more needs to be done still. And it has to be more of a top-down measure. I'm aware that there is already an all sort of group parliamentary committee being formed for ADHD. The NICE guidelines are fully supporting formation of ADHD clinics. CCGs, I think, should be gearing up more towards providing more funding and more awareness, and asking more from NHS Trust in developing more specialist ADHD clinics.
Excellent. Questions are flying in. Let's start with a couple of questions, one each, hopefully. Khurram, give you the starter for 10. So we've been asked the main question, which is obviously, how can adults who suspect they have ADHD get a diagnosis?
I think it's the first protocol is usually the GP, and the first thing, if they're suspecting, then sometimes it's better to have it, to read about it, but again from the relevant and from the credible resources that are available to us. For example, mind.org or rcpsych.ac.uk. These are the websites that will provide you accurate information about it. Again, it is very important to be reading the situation in context, because if you look at the symptomology and phenomenology, there is a lot of overlap in terms of symptoms between ADHD, emotionally unstable personality disorder, bipolar, cyclothymia, and ASD as well. So you have to be very careful whether you're reading in context with that. Again, the context will only come when you see a professional, and one way to see a professional is going to the GP. But again, as Dheeraj said, that the waiting list is massive. Like Dheeraj has mentioned 5 years. I've heard 10 years in a place where, like, it's as if having no service at all for ADHD. 7 years, 2 years, 3 years. That is a very common theme. And Dheeraj has said that there are services which are being created in AD, nice, and the governors and the parliament as well as the CCGs are supporting that. But the problem is the dearth of skills. When you don't have the skills, you will create hundreds of services, but where you're going to get the expertise from? The problem is the training. We don't have the training. We don't have the expertise. We have kind of specialize this specialty. We have to despecialize it, bring it back to the community mental health team so that they are able to see those cases. If you divide these cases between the CMHTs, it's pittance for them. They can do it within 6 months or 7 months. But if you do it collectively, that's a list of 5 to 6 years. So these are the challenges that we are facing from day to day. It's easy to go to the GP, but then GP will either refer you to the community mental health team, who will easily say that this is not my area of expertise because they are not trained in that. They don't have any skill set to deal with that situation. Sometimes they have GPs to have information about the private clinics or private hospitals or private settings. They can do that, but again, it's affordability. It's an expensive assessment to be done. It's not an easy assessment. Plus, the prescriptions, it's the medication, half of it is controlled medication. Not everybody would be able to prescribe that. Again, you need to have that agreement with the GP to prescribe it once they are stabilized. But again, with the private sector, it's difficult to have a shared care protocol unless CCGs are involved.
Excellent. Well, that lends itself nicely, Dheeraj, to ask about medications, I guess. Tell us about some of them at this point. I think we should go on to that. It goes on nicely with what Khurram said.
Surely, but the small disclaimer really, whatever we discuss here about treatment is not personal medical advice, and they should seek professional help. Whosoever is watching and wants to explore it further. But coming to medications, ADHD is treatable. The medication effect size is almost touching 1. Medications are effective, and NICE guidelines support medication as first line of treatment for ADHD. Now, talking specifically about the medication, there are 2 types broadly. One are stimulant medications. Now, I can tell you the notion of, some people asking me, you are giving somebody with ADHD or who's already hyperactive impulsive stimulant medication. I can talk about that later, but in terms of what's available, there's a medication called methylphenidate. It's popularly called for children group as Ritalin. In adults, we tend to use something called as Concerta or Medicanet, another formulation like Equisim. There is also a medication called lisdexamfetamine. This is a prodrug, which is again supported now by NICE guidelines as the first line of treatment. Now, if that doesn't really work or is not successful, or somebody is not, there's no indication or contraindication for the use of this medication, there's something called as dexamphetamine, and these 3 really constitute the stimulant group. Now, there are some patients who may not like the idea of taking stimulants, or they have medical problems or previous psychiatric history which contradicts the use of stimulants. There is a non-stimulant medication called as atomoxetine, which does take a bit longer for acting than stimulant medication. But at the end of it, if the research has shown that they work equally well, both stimulant and non-stimulants. There is a newer medication called guanfacine, which is also can be used. Most of the medications are unlicensed for use in adult group, but the NICE guidelines, the British Association of Psychopharmacology, they support the use of medications in ADHD. There are some, just to add a bit more, some sort of non-mainstream medication which can be used in resistant cases of ADHD, like venlafaxine, or an older antidepressant like imipramine, or there are some medications like antihypertensives like clonidine, and medication used in smoking cessation called bupropion. So they can be used in varying sort of doses and combinations if required.
And Dheeraj, once you start these medications, I guess there is a period of you need to have some tests and assessments done before.
Yes.
And there's also an onus of responsibility in terms of supporting someone once they start on medications, isn't there? Could you tell a little bit more as to what that could be?
Sure. I mean, if you're assessing somebody with ADHD and they want to know their medication options, you have to counsel them on, what is available, what is most suitable for them in terms of their medical history. Now, if somebody has a history of, say, high blood pressure or a history of epilepsy, then I would not advise stimulant medication because stimulants can lower the seizure threshold. If somebody has got history of psychosis, then I would tread very carefully. Obviously, you do not want to increase the risk of psychosis deteriorating if you start using the medication. Then maybe a non-stimulant medication like atomoxetine might be helpful. Now, obviously, before starting any medication, you want to do physical health workup that includes some blood test and an ECG is the bare minimum. Medication, and then you want to do physical health parameters like heart rate, blood pressure, the temperature, their weight, which after starting the medication has to be monitored very carefully.
Great. And I guess over to you, Khurram. What causes ADHD? I know we've gone straight into treatment, and I guess it kind of lended quite nicely with how the discussion went. But what seems to be the trigger?
So Dheeraj has said that it's a neurodevelopmental disorder, so people are born with it. Again, the etiology is not very clear about whether there are environmental factors which are associated with it. But this appears in children around 3 to 6 years of age. The average age of starting somebody on ADHD medication or diagnosis around 7 years of age. So it is a neurodevelopmental disorder. People are born with it. So at the moment, the theory states that it is not environmental, or there are some environmental factors that can exacerbate it, but nothing that can cause it.
Yeah, and I guess you're referring to perhaps perinatal exposure, whether it's about smoking or alcohol or such difficulties. Yeah. Go on, Dheeraj, you're about to.
Good.
Yes,
Excellent.
I was just going to add to what Khurram has nicely detailed. Well, we have to remember ADHD is a genetic disorder. I mean, it's highly heritable. Twin studies tell us that it's almost up to 80% heritability, and in dizygotic twins, almost 35%. Now, if you have a family member, or like immediate family member, parent or cousin, or your own child, you're more likely, almost 4 to 5 times more likely to have ADHD. Now, as you just said, yes, there are certain risk factors: low birth weight, having a brain injury, maternal smoking, maternal alcohol or drug abuse, that can increase the risk of developing ADHD later. There is a lot of evidence when people sort of looked after children, they're more likely to be diagnosed with ADHD. There is a big Romanian study where they have seen children tortured, had high risk of developing ADHD later. So risk increases in sort of a lot of diverse conditions, but you cannot really pinpoint one single cause why this person has developed ADHD later.
Okay, good. Khurram, we've got lots of questions, and I want to get through some questions as it helps us just to break up the show slightly. Someone's asked can having ADHD trigger any other health conditions or issues, or is it a standalone condition?
I think it can coexist with so many other things. I think it can comorbidity with autism spectrum disorder is quite high. With depression is quite high. Social anxiety, generalized anxiety disorder, it is quite high. But again, what we have to notice is it is more so. It is more towards higher side when it is the ADHD is untreated. Secondarily to an untreated ADHD, people can develop strong depressive episodes. They can have extreme anxiety because all their life they have to bear with the energy, and that there comes a time when they are unable to deal with it. They feel lethargic at times. They don't know how to regulate themselves. So all these issues, they mainly come with untreated, but with the treatable condition of ADHD, ASD is one of the most common theme that has emerged.
By ASD, you mean autistic spectrum disorder?
Autistic spectrum disorder.
Yeah, sure. Dheeraj, another question. Hope you don't find these too hard. Let me know if you do. But they're really interesting tonight. So why are parents so frightened of or against having their child tested and recorded as having ADHD? So obviously we broadcast to various different communities in the UK and worldwide, and without marginalizing specific communities and naming them, but there may be certain subcultures which may find that it's better to not label your child in this way. Can you give some ideas as to the thinking behind the parents in avoiding a diagnosis?
Sure. I mean, even in today's age, there is still a lot of stigma when it comes to mental health issue of any kind, and parents obviously already first worry about the well-being of their children, but they really and it is true for certain subcultures, as you said. They do not want a label, a mental health label for their children. Now they're really worried about the prospects of the child, first of all, and the bad name it could give the family in maybe social circles or neighborhood. And it must also be acknowledged that they do not want, or they're really worried about thinking they are to be blamed, that is somehow they have caused their child to have developed ADHD. Now again, that's related to the myth in the various communities about mental health issues, or it could also be that some people still believe there is no ADHD like that. They don't want to accept the idea. And again, many parents don't really want to accept that their child has a particular form of mental health issue which could predispose them to developing other ones. And then obviously there are consequences when the children are growing up, or what it means when they are adults, or what it means for their prospective life or careers, or partner proposals and other things to consider.
Great. There is a question that I want to pose to you. It's from our YouTube channel, from Imdra, saying, how do you manage physical health monitoring as an independent practitioner? And how do you get GPs to agree to do them? Or do you tend to do them themselves?
I think that's a very good question. Certainly I face in my clinic. Now, I do find most GPs are sympathetic to the idea that, an expert has seen their patient and wants, baseline bloods and ECG to be performed. Mostly they agree. Mostly we get results very quickly, and we're able to start the medication. And also, at the end of the titration period, which I can explain if you want, shared care arrangement can start. Now, there are protocols available in, depending on where you are and what the CCG thinks about, assessments by specialist clinics or private clinics. But there are, at times, I've discovered that, the GP themselves, although they want to help their patient out, they're unable to because they're bound by the local protocols. And we have to send our patients to other private clinics where they can get their bloods and ECGs and other investigations done. It's certainly not always easy, but mostly I find that it's workable and doable.
And Khurram, there's some questions from the audience coming in as well. In terms of assessment, one is obviously taking a good comprehensive history from the person in question, including developmental history, etc. But also in terms of observations and scales, are there any scales that you'd recommend practitioners to consider using?
I think there are two types of, one is screening and one is diagnostic tools. I think screening tools is one of the tools that I use is ASRS, and Connors is also used, which helps with aids in diagnosis. For adults, you can use a tool called DIVA, DIVA. The version is 2.0, which is quite an easy tool to use, as well as it's quite efficient. It actually caters to the DSM-5 diagnostic criteria. So these are the tools that I have used in my practice. I'm sure Dheeraj will have more information about the kind of tools that he has been using in his practice. But it's I think it's become a common practice to use at least some screening tools in teams, even in community mental health teams or home treatment teams now.
Great. Dheeraj, I think it's a really good point that you made earlier, where you said that all the advice you give isn't actually for personalized and it's just generic. So I do want to just remind the audience of the nhs.uk website there, and it's got some good information about ADHD for those of you watching in the UK that you can actually access. And in terms of the actual risk factors that you mentioned, Dheeraj, obviously prematurity as well, go along with low birth weight, as well. I had a quick read of that before, so I it mentions that.
No, you're right. I mean, prematurity lends to low birth weight as another sort of risk factor, and a lot of times, birth complications, anoxia, hypoxia, which may not be immediately visible as a brain injury if you do brain scan, but inside the brain working and the functionality does affect on a long-term basis.
Yeah, good. Khurram, we've got a couple of people asking similar questions, so let's amalgamate them into one question for you. So I'll put one on the screen for you. You may recognize the name. And it's asking, should we assume that the problems related with ADHD among adults with specific learning difficulties not necessarily improve, rather than can only be coped with? I think not coped with. In addition to that, someone else was asking a similar theme as to, is ADHD a lifelong disorder, or can someone be relieved of it through treatment or special exercises? I think there's a couple of viewers there who are really wanting some hope from you both, really. Can you shed a bit of light on this aspect?
So again, like many other conditions, ADHD is a lifelong condition. There is no cure, but we can manage these conditions. Again, I think we have to look at it in a context. For example, physical health condition, we get hypertension or cardiac diseases or epilepsy or asthma. Again, these are lifelong conditions, but we manage them. Just like that, there are certain mental health conditions that are managed on a lifelong basis. But the good thing about ADHD is the ADHD medication, when somebody is diagnosed and put on, it is a life-changing experience for them. I think Dheeraj should tell you more about it, because in my private practice, in my practice, which I have done in NHS, it changes a person's life. And the earlier the intervention in ADHD, the better it is, because it will give person the quality of the life. I've never seen such an effective treatment for any other mental health conditions as I've seen for ADHD.
I guess that kind of lends quite nicely to yourself, Dheeraj. I guess the effect is quite, you do see it quite quickly. And when we compare it to other kind of psychotropics that you use in mental health conditions, why are we not promoting secondary care service to ensure that they have this as part of their core business? Because there are some talks, especially, let's say, for example, Greater Manchester, they're looking at trying to ensure that there is a service that's available to all parts of the GM, because at the moment it's not consistent. And I guess we know the reasons why, but it just takes a little bit of ownership and leadership between both primary and secondary care.
I mean, you're right. The services are still quite, early in their developments and still are quite sparse. And there is still a postcode lottery, if I may call, when it comes to ADHD provision. Now, clearly, services, funders, commissioners, the government, they need to do more, because as time grows and more children, develop into adults, the need for service is only going to keep growing, and the waiting list is going to become longer and longer. And I firmly believe in the idea, treatment delayed is treatment denied. Now, certain bigger group charities as UKAN or Action ADHD and other charities involved in the matter are doing what they can. Both the government, the CCGs, the local people, the political people need to do more, and we need to have more and more awareness and people asking for services. I think when the people having problems through whatever voluntary councils or their representations into the governor bodies of their local mental health trust or CCGs start asking for more, I'm sure things will change. They are changing, but I'm sure they will change for better.
And Khurram, I just wanted to ask, why is it important to treat ADHD? What are we trying to correct?
I think it's life itself, the impact it has on a person. But people, they aren't able to calm themselves. I think what you have to understand is they go through a traumatic process of being misdiagnosed over and over and over again, and not finding a reason as to what the cause of it is. Some people, they revert to drugs, recreational substances. One of the most common theme that I have seen is cocaine and weed, cannabis, because it tends to calm them down. And again, cocaine is a stimulant, and it does have a calming effect. It does not imply that people should go and start using cocaine, but this is the kind of impact, and all of a sudden their life goes into a complete haywire. In the forensic settings, they say in the prison population, 40 to 50% undiagnosed ADHD cases. So criminality comes with it, the drug and substance misuse, the impact on the resources, for example, A&E, the fire department, the police, the ambulance, the secondary care, the primary care. Imagine the amount of money that we're going to save if we treat them early. And again, I don't understand. It's common sense. A condition, for example, a psychotic disorder, which is the prevalence is around 1.2, 1.3% globally. You have every possible services catering to it: inpatients, community mental health team, early intervention services. Where there's another disorder, whereas there is a prevalence of 6%, probably more, if we actually start diagnosing them properly, both in adulthood and childhood. Probably it will be more. So looking at a 6-fold increase of patients with lots of severity, co-morbidities, and there is no service for these patients. So imagine the burden on the community, the burden on the resources. Imagine if you have the skill set to deal with it, things will change dramatically. I work in a home treatment team, the crisis resolution home treatment team. 30% of caseload is ADHD. And what I've started to do is I've checked with my with chief pharmacist. I've started prescribing atomoxetine for them, Strattera, because it's a second line, but we can use it. We have this arrangement with the GP consortium that we can do that. We are not supposed to prescribe, and there isn't any service in our area for ADHD. So it's just common sense. I think people have to look into that. Why aren't they doing it? There is a skill set available. If it is not, you can train them. It does not take more than 6 months or a year to train lots of professionals in that. You can incorporate it in community mental health team, in inpatient wards, where people are misdiagnosed right, left, and center. And again, that is causing a lot of problem for everybody, for secondary care, primary care, as well as the community itself.
Excellent. Dheeraj, I'm going to give you a couple of questions, but I'm going to be fair. I'm going to give you a minute to think about them. And whilst I do that, I'll talk about some future. well, you got to be fair, just so I can then plug some of the other stuff we're doing. So the questions that have come in is to do with incidents and is there an increase of ADHD in people or not? So if you have a think about that, and also going on from that, someone's asking about ADHD assessments and treating it at the moment under pandemic restrictions, if there's any difference from face-to-face. While you just consider those things, I just want to mention coming up next week, we have a dermatology seminar. So this with Dr. Ian Coulson and Lucy Moorhead. We're discussing dermatology. Dr. Ian Coulson is based in East Lancashire. He's a consultant of over 30 years. And Lucy Moorhead is from down south in London, based near London. So please do tune in next week. In addition to that, Mehran and I, as part of Med Talks, we're doing another global webinar. for a free COVID vaccine webinar to do with the COVID vaccine. We have two experts coming to join us. Dr. Mohammed Munir, who's a virologist at Lancaster University, and he's actually been doing some of the research to do with the actual COVID vaccine in the UK in one of the select laboratories, and also Dr. Sarah Zaidi, who is a double Ivy League graduate of Brown University and Harvard University, a public health specialist. Your eyes went wide open there, Dheeraj, when I said that, I know. So we're really fortunate to have both of them on Wednesday, December 16th at 7 p.m. So the sign-in details is there, tinyurl.com. /COVID vaccination, and that's a Zoom meeting coming up. Right, that's enough advertising going on. Back to you then, Dheeraj. You've had plenty of time to consider those. Tell me a little bit about incidents and also about how you're actually assessing people in this pandemic to do with actually, is it a face, because you're not face-to-face, or how you're managing in telepsychiatry remote consultations?
Thank you. I mean, before I answer your question, I must say you guys are doing a sterling job, and I wish you really all the best in increasing the awareness about various topics that you do. Really well done. It's a great initiative. Now, to answer your question, ADHD, increases the risk of all sorts of incidents, whether it's in the childhood, children falling over, having more fights, not really having a sense of danger. Children, I have worked in children's services, and I used to do an ADHD clinic once a week, and parents would come in, my child falls more often, has no sense of space and no sense of boundary, bumps into things, that spatial awareness is not available, they have more fights. Yes, there is a risk of incidents, and then there is a risk of brain injury as a child, and any attendances, road traffic accidents, running into road, running ahead of their parents, all sorts of issues. Now, those problems, if you take them to adulthood and driving, people with ADHD are more likely, almost 9 times more likely to have road traffic accidents. And once I see somebody in my clinic and they have ADHD, and I know that their ADHD has caused driving accidents, I advise them to contact DVLA and inform them, because untreated ADHD increasing the risk of driving accident is a reportable matter. And then, people getting into fights, people doing impulsive things, getting into trouble with the police, speeding fines, losing licenses, getting bans, and then, getting arrested for, say, fighting, or, having stolen something out of their impulsivity, or getting into other kind of serious criminal activities. People with ADHD are 9 times more likely to end up in prison. Now, as Khurram was saying, ADHD is overrepresented in prison population, up to almost 40%. It's the second most common mental health disorder after personality disorder in prisons. So yeah, the risk of all sorts of incidents increases. Now, if you talk about somebody's personal front, there are more incidents of domestic violence in people with ADHD. Now, if they are taking drugs, and the risk of taking drugs is higher in people with ADHD, the risk goes manyfold higher. And then there are problems at workplace, getting fired and expelled from jobs because of disciplinary issues or non-attendances. So life can be really difficult with ADHD for a lot of people.
And Khurram, is there anything you want to add on in terms of life and what it's like for people with ADHD? We've had people asking today as well, really, about the actual struggling with ADHD and really what more that can be done for them. Is there anything else that you can offer, either websites or resources for people to find out more?
I think there are, as Dheeraj has already mentioned, I think there's some ADHD trusts who are. I will forward you the websites, links later on. I think I have got it with me. As there are some voluntary organizations that are working towards it. However, I think going back to what Dheeraj was saying, people with ADHD who are undiagnosed, they're kind of lost entity. They have found the answer. They feel as if they are just like a person with autism disorder, they are like an alien in this world because they are not able to manage themselves. They are labeled with so many different things. They are misdiagnosed with so many conditions, and plus the impact of this that is having on the community, it is massive. I think the injuries in childhood because they want to be outside, they've got so much energy, they have to get rid of energy to get into sporting activities. Again, having excessive activities of those kind can have an impact on the body as well. Um, I think it is a condition which everybody has to think about on a broader level. There need to be more bridges between primary care and secondary care, and CCG is providing more funding in order to help the communities. And I'm talking about communities. Communities are the one that are suffering quite a lot because of that.
Great. And just following on the treatment discussion, Khurram, and we have had lots of questions. Well, one is about medications. I think Musarat was asking about medication holidays or as needed medications. So there's certainly an element of that. So if you focus perhaps on adult ADHD, or it's up to you. You can talk about children, because I guess the service is a bit more geared up to support them. But in addition to that, people should be aware of interventions in terms of parent training or behavioral interventions as well. Could you just make sure that the public is aware what they should be offered?
Yeah, I think once a person is diagnosed with ADHD, mostly in children, parental training is available. ADHD do send people to parental training. Bernardo's, they do provide specialist training for ADHD. They also do it for autism spectrum disorder. And that's a very useful training, quite effective, which is focused and geared at ADHD. You're asking about medication holidays, which is very common amongst children after a certain time, so that the body shouldn't get immune to it, especially if they're taking stimulant. But in adults, that's what I've noticed. The intensity usually comes down, especially if they have got hyperactive, unless there is a comorbidity which is attached to it. So in that, I think kind of low to moderate doses that actually do very well. And I've not come across, because we have not seen adults for such a long period of time in terms of follow-ups. Mostly they are once they have been initiated on medication by the private sector, they go on to the GPs and dealt by the GPs. Again, I'm going back to you, Fahim. Probably you would have seen cases where you might have managed people on ADHD medication long term. I've not come across any medication holidays in adults, but children, it is a very common entity.
Yeah.
Just some more questions flying in. There's one from Christiana just asking about the best test for adult ADHD. Khurram, you did talk about it earlier. So Christiana, we will try and put links on our description. So, if there are any questions, please do contact medtalks@gmail.com. So Dheeraj, just going back to medications, what are the side effects that someone could experience? And I guess in addition to that, the degree of overlap, what's stopping, let's say, someone with substance misuse with a high risk of having ADHD actually having ADHD treatment?
I mean, that's a good question, really. There is still a lot of concern about people having histories of substance misuse and having ADHD, and then getting a diagnosis of ADHD. Then what do you do with their treatment? Now, the important point to remember is there is a chemical difference in which the street stimulants work and the medication which we prescribe work. Now, the brain, the way it works, if after taking a particular form of substance, if it's not reached peak, say for example for 30 minutes, you're not going to like that substance. And the medication that we prescribe, they take at least hour and a half before they reach their peak value in the brain. So the addiction potential is a lot less. Medication that we prescribe have practically a very low street value. The risk of diversion is quite low. Now, it is not to say that that risk does not exist. And if you're really worried about, the drug being misused or the addiction potential increasing, or there is still a parallel abuse of drugs, you can use a non-stimulant medication, but you can still consider something like, a lisdexamfetamine, which is a prodrug of dexamphetamine and takes almost 2 hours to reach peak values in the brain. And the way medications can be used really limit their potential to be used as substances of abuse and addiction. Now you're talking about side effects of the medication. Stimulant medication obviously come with every medication does come with their side effects. Stimulant medication can in the initial days make you a bit more irritable. They can have an impact on appetite. You can get headaches. In the longer term, the kind of side effects which we warn our patients about and we really worry about, and that's why we tend to do follow-ups, is the risk of seizure threshold decreasing or their blood pressure increasing, and those are the ones to watch out for. We give appropriate advice, safety advice when that, if and that was to happen. Now that's with regards to the stimulant medication. If you ask me about non-stimulant, say for example tamoxifen. Now the more concerning side effects can be the impact on the liver, or a major change in their irritability status, or sometimes experiencing suicidal thoughts. Now, if that was to happen, our advice is always stop the medication, contact a professional. But that also gives the rationale why you want to have baseline assessment and baseline testing done before you make a choice of the medication that you want to prescribe.
Excellent. We're running near the end of our show, so last few minutes. So we will ask both our guests for their top 3 tips in a few minutes' time. Before we get there, I've got another interesting question. Bridgeway consultation. Do you have talks around autism as well? Well, I'm glad you asked that, because guess what? We do actually. And it was with one of our very own guests, Dr. Khurram Sadiq, back in September 15th, Khurram, if you remember that show that we did with you. So absolutely, if you go onto our Med Talks channel, you'll find it there. And whilst we've been getting that all up, I've actually got that ready. So I'll put that on the screen as well for you to have a look at. And there's over 30 of our shows there. Khurram, I want to ask you a bit more about etiology as well now. A lot of people are asking about ADHD, and obviously, is it a neurological issue or psychological, or is there any relationship to the rise of social media, IT, and these sort of things? And I know this is a bit of a special interest of yours. So how would you say social media, gaming perhaps, or other things where there's a lot of the senses being played is actually a part of the ADHD paradigm?
So with ADHD, this and the advent of social media, it makes ADHD worse because the attention span decreases, and basically the release of dopamine. That is one of the culprits for that. They can, for example, with ADHD, they can engage in certain games because the format of the game changes so quickly, so that kind of gets their attention. But again, their attention span otherwise decreases substantially. Social media itself or gaming disorder does not cause ADHD. Again, it may causes worsening of inattention. Again, a kind of withdrawal from social media and gaming disorder may cause a rebound hyperactivity, rebound aggression, impulsivity. But there are no studies as such in the pipeline or have done in the past that has indicated any connection. It does, I think, in terms of the clinical practice, what we normally see from day-to-day basis is the social media and gaming does impact the severity of ADHD. And that is true.
Excellent. And coming to you, Dheeraj, the panel, but it's going to be you, Dheeraj, specifically. You are the panel now. Aware of any breakthrough research which challenges the genetic sort of idea behind this? So, for instance, someone trying to get some idea of environmental or social virtual factors that are causing ADHD. Can you give some hope to one of our listeners that it's not just genetic and there may be something else in the water?
Well, scientifically speaking, ADHD is a disorder, a mental health problem with a high level of hereditary component, almost 70-80%, is a neurodevelopmental disorder. It is a biological disorder. But obviously, genes in anybody lend up to development of a specific mental health issue, but it also, as an expression of the genes on the behavior, can give rise to certain social environments or the social consequences with regards to not achieving potential in life, or not being successful with regards to education or profession, and then having risk of a certain home environment where the problems persist. So that will probably impact on an earlier expression of the illness or the problem, the severity appearing more. But I am not aware of any research which says it's a social construct, and ADHD happens because of your social problems.
Great. I think our 1 hour is approaching. So I'm going to, because you are on the mic, Dheeraj, I'm going to give you first dibs. Can you share with us and the audience 3 tips with regards to ADHD?
If you ask me for 3, I will say, get help. ADHD is treatable. Don't suffer in silence. If I may add 2 more, my 3 is done. Self-help is possible, and if you are dealing with a bigger problem, break it into smaller achievable parts, develop SMART goals.
Fantastic. Thank you, Dheeraj. And Khurram, 3 tips.
So in terms of obstacle, do persevere if you think your child or yourself are having the symptoms which is consistent with ADHD, because sometimes the professional do not pick up on the first instance. So do persevere if you believe that is true. Seek help. If you're on medication, don't stop medication.
Fantastic. So I guess kind of my own personal take on this, everything's about early identification, isn't it? And the approach to this is multimodal. So there's no one method of addressing this, but if you address it earlier, then your outcomes are much better in terms of occupation, in terms of integration with society. There's abuse or absence of abuse of street drugs or substances. That can only be a good thing. So there's clearly a need there, and I'm sure this conversation about ADHD will continue, but I think it's apparent that during COVID-19, vulnerable groups need greater attention. I think ADHD are part of that vulnerable group, especially if children have to study from home or don't actually go into school. Dheeraj, you're about to say something there.
I was about to, I just remembered your question about, remote assessments. Yes, lockdown has not been easy on anybody, especially for people with ADHD. And psychiatry is well suited for remote telemedicine, and remote video assessments are very much possible for ADHD.
And I'll add one thing. Sometimes the remote assessments actually is a telltale, because patients with ADHD, they are unable to sit with one. I have seen people walking around the whole house with a camera, with a phone in their hand, and again, those presentations which are supposed to be seen by the professionals in order, and it makes things easy for them. So sometimes, although it is difficult, but diagnostically and looking at the presentation, it becomes easier for the professionals to see that.
Fantastic. And thank you again, Khurram and Dheeraj, and especially to Fahim and the audience. Please do subscribe to our show. We'll hopefully see you again next week for a discussion about dermatology. And look forward to meeting you all there. Fahim, any last words?
No, I just want to thank Dheeraj
You're
and
welcome.
Khurram from really, it was really important topic. We've been flooded with questions,
Yes.
and I think we should acknowledge that. So thank you. There's been a lot of engagement on all our media, and forgive us if we threw you with
No,
some
you
difficult
didn't. You were
curveballs
gracious
tonight. But
host, and thank you for having me.
great. Well, I hope you come back then for
Yeah.
another time. You fell into that one, Dheeraj. Okay.
It's all right.
Thank you so much,
As
and
I
good
said,
evening,
pleasure.
everyone.
Thank you.
Thank you.
Thank you so
guys.
much.